We're now back recording. Welcome, mesdames and messieurs. So before we get to this, I just want to finish up. We remember did the blood-brain barrier, so we don't have to go over that again. It's interesting. The terms are slightly different when we talk, and they don't have it in this PowerPoint, between the brain and the spinal cord. When you hear about a concussion, by definition to the brain is temporary, where a contusion implies that there has been some type of permanent damage to some of the central nervous system structures. It's sort of, if it's interesting, it's opposite that a little bit. With spinal cord injuries, the concussion is more problem. That's what happened to Ryan Shazier, the football player for the Steelers, not that many years ago, when it eventually ended, which immediately ended his career, as was fairly obvious to somebody who's looked at that stuff over many years. A contusion in the spinal cord is more of a bruise, where the concussion implies more significant degree of damage. So as soon as they came out with the diagnosis after that play against Cincinnati, and he said it's a spinal concussion, I'm like, it's not good. So that's it for him. And so it depending on what part of the central nervous system. So I thought I'd throw that in there. So typically we see a lot of concussions. The problem with concussions is when they occur quickly, successively quickly without recovery time. That's what happened to Sidney Crosby, where he got 2 concussions within about 10-day span. And then you go from first level to second. Once you get to second level, there's a problem. That really affects people long term. And there's a very famous guy played for the Penguins, who originally for the Islanders, Darius Kasparaitis, a tough hitter, Russian player. And when Penguins acquired him, he had a good stint with him. He, a first round overall draft choice, number 1, like Crosby was, named Eric Lindros, was a great player. And he wasn't watching where he was going. He wasn't paying attention. And Kasparaitis had a perfectly legal shot that caused a second level or a second degree concussion. I mean, it was never the same. This is a guy who was an MVP candidate at the very least, if he didn't win one. It's so we underestimate the potential problems, and when they're successive or recurrent, as we see so frequently, not just in sport but in life, that's really significant. So even though it's temporary, the severity of it is magnified if there's inadequate recovery time. Might be the way to describe it. We talked a little about this when I talked about the meningeal areas, the distinction, the subdural or subarachnoid bleeds. The problem with that is you have nowhere to go. The brain just doesn't have any potential of going anywhere. So any additional fluid or pressure is going to not only push it down into the foramen magnum, but damage. And that's one of the sources of significant damage, as well as cerebral edema. So that's where you're looking at with this. And there's a lot of mistakes. And I mentioned it before, and I'll mention it again when we get to that next slide. When they talk about a stroke, by definition, okay, we refer to it as an infarction. An infarction is death of tissue from lack of blood supply, either total or relatively speaking. So it means, for whatever reason, the tissue is dying because it is inadequately, in the term we use, perfused. That's there. So ischemia, deprived of blood supply, leading to death. And it can be a blockage, it can be a variety of things. And then what aggravates it, after that, the damage typically manifests itself with something where glutamate, which is a neurotransmitter, and it's basically the amino acid you're familiar with from biochemistry, glutamic acid, just like aspartate and glutamate for you guys in biochem now. Those are consistently very much excitatory for the most part, and it does worsen the condition. And what does happen, because of the contralateral aspect, we see what's called hemiplegia, half the side. So if it's on the right, it's on the left. If it's strokes here on the right, and you may be gesturing up there. The spasms from the excitotoxin cause contractures, and since flexors always overpower extensor, you get what's called spastic hemiplegia, and that's one of the distinctions. It's very hard to rehabilitate. This is true damage. If someone has a stroke, and I take issue with this, pet peeve, I know that. It's not a mini stroke. Oh, grandma had a mini stroke, but she's fine now. No, grandma had this, TIA. Transient ischemic attack or transient ischemic episode is just that. It's transient. By definition, it's reversible. Yes, maybe they have double vision. Maybe they faint. Maybe they kind of don't know where they are for whatever reason. But it doesn't mean that the damage is permanent. That's why it's not. There's no such thing as a mini stroke. It's like I'm fond of saying. It's like saying I'm a little bit pregnant. It doesn't work that way. Okay. And so now, years ago, we used to use streptokinase, an enzyme we would harvest from Streptococcus. Now they use what's called TPA, or tissue plasminogen activator. We'll cover that in detail next term because we do the blood and the physiology portion of the program. And so what that does is it's a clot buster. And so in areas where the strokes are a real problem, particularly when there's a lot of older folks, where you see a lot more of it, most emergency rooms have this handy and they can introduce it by catheter within a window of time to reverse the effects. And what I may have mentioned my aunt was because she was retired in Florida, elderly, deceased now, but that type of thing. So, which brings us to we make the mistake of saying every time we see aspects of dementia and saying they have Alzheimer's. Alzheimer's is very specific. Okay. And I'm not overly sensitive to that because my mom succumbed to it because she's one of many moms. And my mom lived to be 93 years old. She had a very good run. She was driving a car until she was past 86 years old. I may have told you, as good as my vocabulary is, my household, I was third in Scrabble. My sister is an English teacher from George Washington University, who later got an MBA in business, was a vice president for Bausch and Lomb. She was second. My mom never set foot in a college door first. Just to give you an idea. Okay. So moving on. This is by definition progressive and degenerative. And effectively what happens is just, and I told you before, as though when we go through development and increase our abilities, it's the opposite. Now we've crossed over at the top of that hill and we're starting to go down. And so all of those things that we normally wouldn't give a second thought to, of dressing ourselves, going to the bathroom, swallowing, all of a sudden stops. It's almost like we no longer have that capability of doing it. And so what's classic about this, and what did you cover prions in micro? A little bit? Okay, so they're infectious agents by definition. They're acellular like viruses. And prions, which are basically misfolded proteins, they bump into other proteins and cause them to misfold. The classic disease is mad cow disease. But what it has in common with Alzheimer's, and about 5% of Alzheimer's, we can relate directly to a prion infection. It's not just, some people thought it was the sole cause. I don't think that's true, or certainly not been proven. So misfolded, and the proteins begin to deteriorate. So all of these things, memory loss, tension, confusion, irritability, moodiness, etc. But we see certain things that accumulate. So beta amyloid peptides. So we call them plaques. And typically we see those associated with immunological phenomena. So protein clumps can be like that. So there may be an autoimmune component, neurofibrillary tangles. Okay. And so the neurofibrils, which we get to, again, in the physiology part of the program, are sort of the passageways going from the cell body and back to the cell body. So either going proximal to distal or distal to proximal in the context of the nerve. Basically, you can move things back and forth. Materials, they kind of are unable to do that eventually, and they lose the neurological function. And we see certain characteristic findings that now we can see on MRI and PET scan, which they only could do post-mortem, make the diagnosis. Now that's not necessarily the case. So the old days, the diagnosis was made historically and then confirmed post-mortem. Now we have better ways of doing it. So there's a lot of variations. And I think the most tragic ones are the early onset aspects. And unfortunately, they favor women more frequently than men in that. I mean, such people in their 50s and 60s. Didn't Julianne Moore win an Academy Award for Still Alice? I believe, wonderful actress. Okay. So, being able to being able, she was Alec Baldwin played the husband in that, and how she was starting to lose herself doing that. Very, very interesting on that. And so here you can see what I'm referring to, the distinction between, we see a lot of this activity, whether it's a PET or a functional MRI, and you begin to see limitation, and it seems to highlight temporal lobe. Again, because that's so oriented toward memory, that probably plays a significant aspect with it as well. And I talked about this already with dopamine releasing, that nigrostriatal dopamine pathway, that's substantia nigra to the basal nuclei, tremors at rest. The cause, there's many thoughts, okay, as to what causes it, but there's a lot of variation. So sometimes it can be traumatic, can be infection, can be tumorous, causes can be unknown. Some people develop it. There's hereditary tendencies. All of those are part of it. So, I mean, we see different ones. I mean, we see post-traumatic, like with the famous boxer Muhammad Ali. You see people where they get it secondarily because they've had other issues associated. To me, it's when they say pure Parkinson's disease, a lot of times we don't have that. The grandson. He's thrown up all night. Yes, sir.
But they build up more like lactic acid.
Beg your pardon? You would think so. You would think so.
Might be some water time.
Yeah, the trouble is it's irregularities of stimulation, starting and stopping, and those kinds of things. It's a very complicated diagnosis. That's there, but I agree with you. The lactic acid would be part of it as well. And then Huntington's disease, and I told you a little bit about that. This basically autosomal dominant, this irregular, and the movements can be, and it can occur much earlier, but again, typically there are people who have reached adulthood and unfortunately may have already had children, either sired children or children were born to them. And again, the mental deterioration, we see this, and again, we're finding more treatments for it. They did a thing on that in House because Olivia Wilde, who played the one character in House, she had it, or allegedly they were doing some kind of treatment with it. Yeah, and again, this is reflexes, angiography. Now we have with these kinds of scans, it's less problematic. Angiography, the problem is you have to inject it into an artery and use a catheter and get it in the right place. And it's not by any means easy. And ultrasonic blood flow is comparatively easy. We'll get into that a little bit. We did plenty of that using it. And effectively, it's called a Doppler. If you've heard, we hear about Doppler radar with weather. Effectively, it's a high-powered ultrasonic waves, and it reflects off blood that's moving. And when the blood is constricted, it makes a particular sound. When it's going too fast, it makes a different sound. So you get used to it. It's almost like a device on a stethoscope that you can listen to. I have plenty of experience with that. We don't have one here, however. And that concludes really the brain portion of the program. Now we get into the next area, and then we're going to be working on cranial nerves and oodles of fun. We're dissecting the brain. I'm so happy. Oodles. It's like oodles of noodles. Yes, I know. Hey, when my granddaughter used to visit with me or stay with me, I mean, it was comfort food 101. We had more mac and cheese and more ramen noodles than you could shake a stick at. And I love to cook. We got really good shrimp scampi last night. So good. We used a head-on shrimp, and then we take it off and you lightly saute off the shrimp, pre-cook it, and then do the sauce, wine, clam juice, clams, lemon, nice little squeeze of that, lemon zest, of course, happy days. Reduce that, lots of butter, happy days. Over pasta. and a little bit of little red pepper flake just to kick it up a notch. Remember my motto: if you're not sweating, you're not eating. Kick that bad boy up. Moving on. Spinal and cord. Every time I wanted to cook for her, she goes, make pizza. That was, I'd make the dough from scratch. Eat.
My dad used to say that.
If you watch Food Network, crazy haired lady. Shark Fin Boy. Great.
I know who you
You know, I mean, yeah, it's out. She's on all the like worst cooks in America show, whatever. She has all those things. You know, when she goes, it's not easy being cheesy.
and Burrell.
And Biol. It was great. In New York State, she trained in Italy.
I'm not gonna lie, I didn't hear what you said, so.
But
I'm not gonna lie, I didn't hear what you said.
it's okay. I heard what you said. Spinal cord is in the vertebral column. That's all the vertebrae start at foramen magnum. It ends at L1 or L2. That's the big feature. It doesn't go all the way down. We elongate, our bones elongate much faster and not at the same rate as the elongation of spinal cord. That way, the spinal nerves, when they exit, many of them exit below L1 and L2, below the cord. Yes, up and down signals, reflexes, etc. But the big idea, this is the anatomical part of the program. I hate the illustrations. Effectively, you have two enlargements, which is where upper extremities and lower extremities, the cervical and lumbar enlargements, they're enlarged, even though the cord gets technically smaller as it goes from superior to inferior. In those areas, because there's a lot of communications with the extremities, there's subtle enlargements that are there. Okay, so that's the first thing that you begin to see with that. And we'll take a look, and it's different. The dura is arranged significantly differently in that area as well. Well, the first part of it has to do with where it ends. So it ends conically. So it kind of comes to, I wouldn't be on a sharp point, but kind of like that kind of a point. And that's called the conus medullaris, which is in the middle, the medullary area, or the medullary cone. A piece of connective tissue covered in pia mater. Link goes all the way down, not the scale. Here's the sacrum. And that filament kind of holds it in place. It's called the terminal filament, or the Latin phylum terminalis, as you will see. And then lastly, because the nerves are coming out lower, when they're teased out, when anatomists tease them out, they look like a horse's tail. Okay? So the very famous name for that is the cauda equina, which means horse's tail. See? Wasn't that hard? So you can see it here. And what happens is those nerves, even though technically the cord ended here, so this would be S5 or C1, the nerves for, L3, L4, L5, they're all coming out, or the nerves through the sacrum are coming out much farther down. So it's protected by bones, the meninges, but differently, and certainly cerebrospinal fluid. First difference, we don't have that double layer with the openings to create sinuses like we do in the brain. So it's one layer thick. It does not attach to the bone at all, to the vertebrae. Unlike that, posteriorly, even though there's some anterior, it's more generous posteriorly, there's an epidural space which has a lot of blood vessels, a lot of nerves, and a lot of fatty tissue between the vertebrae and the dura of the spine. It's both anterior, it surrounds it. It's more accessible posteriorly, and when you hear about someone getting an epidural, let's say at the time of giving birth, it's not the mistake people make. It's not an anesthetic. It's not eliminating pain. It's not the equivalent of a spinal anesthetic. It's called epidural analgesia. It reduces pain, hopefully if it's given properly. Not the case with my daughter had her daughter. So it's not an anesthetic. Anesthetic means the absence of pain. Analgesic means reduction of pain. So if you got a headache and you take a couple of Tylenol, that's an analgesic. You're going to the dentist and they're working on your teeth, you're going to get a shot of whatever they're using, typically something called lidocaine. And that is an anesthetic because it's the absence. So, and then you have the same thing. You have arachnoid spaces, the arachnoid and the pia, extending all the way to the sacrum and to some extent beyond it. And because of that gap that I didn't draw terribly well there in that L3, L4, L4 or 5 area, those are pretty big openings. That's where we do lumbar punctures or spinal taps or spinal centesis. Any of those names applies. Lumbar punctures and lumbar centesis are medical clinical terms. Spinal Tap is a great movie from the mockumentary people. Anybody ever see Best in Show? Waiting for Guffman. You never saw Best in Show? You saw it.
No, what did you call that?
What?
You said spinal tap or something else.
Lumbar puncture is classically the term, and spinal centesis, centesis. You never saw Best in Show? Did anybody ever watch Schitt's Creek? The two people who are in that, Catherine O'Hara and Eugene Levy, play husband and wife in that show. It's a mockumentary about a dog show a la the Westminster, except they call it the Mayflower. And all the people in their little cadre are hysterical in that. You have to watch that. It is hysterical. Jane Lynch is in there. She's great. I mean, it's just, don't know what you're missing. It's a little body. So notice, so you go through the fatty layer. This is where an epidural would go. Okay, relatively easy injection. But you have to get in between the vertebral bodies, so it needs someone very skilled to be able to inject it and to get into the subarachnoid space. And then you pull out the catheter, the needle stays in, the catheter comes out, it leaves a channel, and you take test tubes and you collect the fluid, 3 in a row. You know you've made it, if it's too bloody, a little blood to start, but the next 2 tubes should be clear, and it's such a vital test because it's really you can make the diagnosis of bacterial meningitis. You can do a gram stain to make the diagnosis of bacterial meningitis, and that'll save somebody's life. That's why it's such a test. I tell it to every class. Babies get high fevers all the time. 104 fevers, not getting admitted to children's hospital. So my grandson, puking all over the place, wasn't going to be admitted with a high fever. Here's what they do. First thing they do with a high fever, if they can't decide right away, they do a urinalysis. Easy to collect. Okay, because it could be a urinary tract infection. Not the baby's going to be able to tell you. Next thing you do is a chest x-ray. Well, what about the blood test? That's not even third. Next step, spinal tap. Because by that time, if you don't have an answer, you better be ruling out meningitis because you're running out of time. That's how it works. That's the protocol at Children's Hospital. At least it used to be. Yes, ma'am. Pardon me?
Why do epidurals sometimes not work?
It's all about whether they have it's technique.
So
If it
depends
has
on
to be
the
injected in the
place.
right place
Okay.
properly. If you talk to somebody who does procedures, surgery, or these types of things, there's 3 things that go. It's like selling real estate: location, location, location. When it comes to surgery, technique, technique, and technique. The biggest problem is not doing it properly. Yes, sir. Sure. I mean, it's a little hard to. It's a matter of if someone's getting an epidural and it doesn't relieve the pain, there's no permanent damage. Getting in trouble is more about what kind of damage it causes. If you're doing one of these, and the only person I would allow to do that on me would be somebody who's board certified to be able to do that. emergency room physician, an anesthesiologist, somebody who's done those before, you're in big trouble. Understand, if you put it in the wrong place, you're up here, that spinal cord is tethered. You can damage the cord. If you go in here, the beauty of that is the nerves are not, so you can, they'll give. You're not gonna shove a needle through a nerve. The spinal cord. Now you can put a significant permanent. The short, look, I've been on the wrong end of malpractice suits. It ain't fun. Even when you don't do anything wrong, it ain't fun. Because a lot of times it's the result that governs it. You know. So it's difficult. I can deal with lawyers. It's aggravating and it's time consuming. So here's the conus, here's the phylum. They have little things that hold it called denticulate ligaments, and you'll see them. They anchor. We have the enlargements. By definition, anything that protrudes, and we're going to do cranial nerves before we do the brain dissection because you need to know that, is in lab today, anything that sticks out of the brain or the spinal cord by definition is part of the peripheral nervous system. Central nervous system, brain and spinal cord. Anything that protrudes, comes out of it, PNS. So paraspinal nerve, cervical and lumbosacral enlargements, cauda, same illustration. You can see these are, when a nerve comes out, it doesn't just come out as a solid nerve. It comes out from multiple areas. So we call those little roots joining together to form one nerve rootlets. So that's very characteristic. The mistake that people sometimes make, if they don't know, is, oh, it just comes right out, just one big piece. But it's not, it's multiple areas. And that's why it can affect a lot of different things, as you will begin to see as we get into the distribution of these nerves, which we will not do today. We'll show how these nerves come out and frequently sort of overlap with one another in something called the nerve plexus. And that eventually leads to things like the femoral nerve or the sciatic nerve or the musculocutaneous nerve, phrenic nerve, etc. You can see the girth of the spinal cord. Dorsally, there's somewhat of a little indentation on the cord that you will see they call the dorsal median sulcus. And I'll show you how a better way to see whether you're looking at anterior or posterior. These are cervical vertebrae in this area, foramen magnum's up here. Thoracic area, a little bit different. Okay, you don't see quite, there are still rootlets, you just don't see them quite as many as are there. Now when we get down to the lumbar, now we see the termination of the cord. So there's the conus. So again, it's not to a sharp point. It's kind of like, just a conical would be the best way to describe it. I used to talk about it in terms of cake cone versus sugar cone. Cake cone, sugar cone. Bite the bottom of the sugar cone. You did that. See, she's normal.
We all did that. You don't think so?
Nah, maybe. So my wife and I were having mint chocolate chip moose tracks last night. That's good stuff. Hey,
You should bring some in.
it's a giant eagle. Go buy it. I'll give you the $3. Go get it. Bring it back for everybody. It's not that expensive. Heaven only knows what's in it to flavor it. It's what we call a chemical feast. It's not like naturally occurring ice cream.
Sure about that?
Yeah, I'm pretty sure about that. Like those flavors are there. So here you can see the conus. Here you can see the cauda. The phylum is a little hard to see in that illustration. That's there, and you can see the segments that we talked about before. Not much to see there. So there are two grooves that run along the cord, both ventral and dorsal. And again, we use those terms more frequently in the nervous system than anywhere else, because we typically use anterior and posterior, but because this was really the first system that was discussed, we look at ventral and dorsal a little bit more. So Dorsally, it's a little wider, if you will. That's about the distinction that's there. And it's very similar to what the brain is, except we don't have those islands of gray matter. You have the central canal, which is the extension of the ventricles. So it's filled with fluid, and the fluid exits to the bottom. It can go out and surround it on the exterior. It has a very distinctive gray matter surrounding that, and then you have white matter, period. So there's no additional islands of gray matter. So the central canal runs the length, etc. And this is a classic. This is cervical, as you can see. You see the transverse foramina that are there, and you can take a look at the distinction. You can see the openings that are there, and it has this, if you want to call it a butterfly shape, whatever you want to call it. People letter H shape. There's a lot of different things, but you have white matter and gray matter. And as later on in this PowerPoint, we'll look at some of the tracks, which are the white matter that's going up and down in various areas. You can see there's both dorsal and ventral roots that are there. Dorsal, sensory, incoming, afferent. Sensation is coming in posteriorly. Motor signals are going out anteriorly. In general, the gray matter goes all the way to the edge, and it truncates or ends just a little before. So typically on the anterior aspect, you can see white, but on the posterior, the gray matter is much more difficult to see. That gives you a clue as to the orientation. The gray matter are called horns. So this would be a dorsal horn and a ventral horn. There's also a lateral horn that we see in the thoracic area, particularly, and to a little lesser extent in the lumbar area. That lateral horn that you will see is typically where the nerves originate that are part of the sympathetic nervous system, which is really important. So they come together, and what we find characteristically in the intervertebral foramina as it's exiting, this is called the dorsal root ganglia. Sensory nerves are bringing inputs in from any of the sensors, hot, cold, sharp, dull, whatever, and the cell bodies accumulate here. So the cell body is somewhat offset, if you will. So this would be there'd be a sensor here, it's a dendrite, a long axon, the cell body, and the continuation of the axon enters eventually into the spinal cord itself. We'll go over some of these, but we'll probably get to that Wednesday rather than today. Exactly the pathways of the tracks that are there. So that's another part. Why is that dorsal root ganglia important? That's where herpes viruses hang out. And they become latent, and they're all latent. If you had a herpes virus, if you had HPV, which is in a different system, but what latent means in terms of viruses, that virus is with you forever. Will it recur? Not necessarily, but you have it forever. Okay. There's different things that make it come out. So that's why we see a lot of variations with regard to that. Here are the rootlets. Blood vessels generally anterior and posterior. The columns are the white matter. Other names that we'll give them, we'll call them funiculi. Funiculus being a signal. White columns are fine, okay, and horns for the gray matter are fine. This is that lateral horn I was telling you about. That little point there, but it's not in all areas. You can see the rootlets, you can see the dorsal root ganglia. What comes out here and here, these rami, okay, can be mixed. They can be both dorsal, they can be both sensory and motor. But the pure nerve itself coming in here is sensory, going out here is motor. And you can see the coverings that are there, the dura, the pia, and in between there, so to speak, would be the arachnoid layer. So letter H, whatever you want to call it. The horns themselves are receiving input, okay? The ventral horns are outgoing output. The lateral horns, again, thoracic and superior lumbar, strictly sympathetic. Sympathetic's a big player because your blood vessel diameters are well controlled by the sympathetic. Big player. The sort of the bar of the letter H, or the bridge between the gray matters, is called the gray commissure, and the central canal is in it anatomically. And then you have the roots and the dorsal root ganglia, and the fusion of them effectively is the nerve. So when we look at the spinal nerve from L1, for instance, L1 has a combination of sensory and motor components. And so by and large, they're all mixed. And then depending on how they distribute, as we will see, it changes. And so we can divide this anatomically. I don't have you know this, but I'll show you it. So that lateral horn where it says that, that VM means visceral motor. That's autonomic. We don't have any control over them. But by and large, you can get sensory dorsally, be it from visceral, or somatic means from the body, bones, muscles, joints, and then somatic motor going out to those same structures. White matter is mostly myelinated, but there are some myelinated components inside, non-myelinated rather. And so you'll have either one's going up, by definition sensory, one's going down, by definition motor, and ones that are commissural. So we're going to, at some junctures, we see crossovers in the spinal cord as well as in the brain stem itself. So in certain, and we know the way these tracks go, so you'll be able to see that. I'm not going to ask you specifics about that, but I want you to be familiar. The sensory pathways generally have 3 levels of nerves, well, first, second, and third order, and we'll get to that. So where they cross over is not something I would hold you to at this point in your academic careers. Don't have to thank me. I give you enough material. And here's the white matter, same thing, dorsal, lateral, and ventral. Axon, similar destinations, pain fibers to wherever. Same illustration. The tracks. So these are called the dorsal columns. And when they're big enough in certain areas, we begin to see the 2 different fascicles. Again, I'm not going to hold you to gracilis and cuneatus and what they do. But the dorsal columns are really important. When I was telling you about all those proprioceptors, they're coming from the dorsal columns. So that thing we talked about, the cerebellum and Romberg sign and the field sobriety test, that all involves dorsal columns. And the other part I mentioned too, I just want to reinforce here, is this is where we see tertiary syphilis. So syphilis was rampant, then we started to go away. Now we're starting to see a comeback of a lot of sexually transmitted diseases, particularly the ones that we thought we had really a good handle on, which were syphilis and gonorrhea. And so tertiary syphilis is late stage for someone who is either untreated or undertreated, and inevitably it involves certain areas that are really damaged significantly, and this causes a particularly irregular gait. And the name of it is called tabes. That's the unsteadiness, TABES, dorsalis, because it affects those columns. And again, just like somebody whose cerebellum doesn't work, or a diabetic who loses the sensors in their foot, they walk like this, they have to watch what they put their feet. That's why I see a lot of diabetic patients I got pulled over for public drunkenness, and they find out their blood level alcohols are 0. So in the blue are the ascending tracks, the spinothalamic. That's the lateral spinothalamic, not so much the ventral one, this one over here. That's the basic pain, sharp, dull, hot, cold track. So when you grab something and you get a major ouch, it's coming through that. The big one that tells you what to move my arm, move my hand, that is the lateral corticospinal. As you can see in red, it is a descending track. You're going to see that it has 2 components, upper and lower. So sensory generally 3, motor generally 2. And you can see there's other ones that are there that play a role. When we talk about, we call these pyramidal tracks, and the ones that are not, like rubrospinal from the red nucleus, vestibulospinal from posterior aspects of the brainstem, tectospinal, which plays a role with the cerebellum. All of those are what we call extrapyramidal. That's where another thing where we see Parkinson's-like activity. We see irregularities and shakiness and things like that. Some people have them naturally. They just can't. I mean, I always had hands you could hold steady forever, which is useful because it's always annoying to patients you're going to operate on. Hi, what procedure am I doing on you today? But extrapyramidal is a real interesting area for you. If you're going into a medical field, a lot of medicines produce extrapyramidal side effects. It's a real problem. So here's the spinal cord trauma. So injury to the cord or its roots leads to different things. There's a big distinction between paresthesias and paralysis. A paresthesia is an alteration in sensation. Okay. So, and again, I use the diabetics because they're a classic example of that because of alterations in their spinal nerves. They have to, I would tell them, listen, before you if you're running a bath or something like that, check the water temperature with your hands, which are less effective than your feet, to make sure it's not too hot or too cold. Okay. They couldn't distinguish that easily with things. So a paresthesia is an alteration, not a true lack of sensation. So something that you might feel hot to you when in reality it was cold. You might feel needles and pins. You know, that's typically what they were like. Feeling like your foot was asleep or your arm was asleep. We normally get that from holding it in the wrong area. Okay, where paralysis is certainly motor. So motor function loss, and there are two types, flaccid and spastic. It's a two-nerve circuit. So you have one, the first nerve is brain to somewhere in the spinal cord. That's called an upper motor neuron. So that's basically your brain sending a signal to the appropriate area of the spinal cord to move your arm. The lower motor neuron is going from the spinal cord to the muscle that's going to move. So they're different. When the damage is an upper motor neuron, it creates an irregular signal. That's where we tend to see spasm. That's what happens in stroke. Okay, the overproduction of glutamate, typically associated. Where the lower motor neuron, the message is not getting to the muscle. The muscle's not being stimulated. The muscle's not stimulated, it basically stops functioning the way it's supposed to. It's flaccidity. So it loses its oomph. It's like if any of you were in a cast or immobilized for a long time from an injury. You know, for young people, a couple of weeks in the cast, they take the cast off, you feel, oh, what happened to my arm? And then 2 weeks later, it's fine. Okay, because it's temporary. So that's the difference between spastic paralysis and flaccid paralysis. So flaccid, ventral root or ventral horn. Impulses don't get, there's no voluntary, involuntary control, and the word we use is atrophy. The classic disease that causes this, very famous, and it hasn't left us. It's just that we're all immunized for it from when we're very little. It's called polio. And polio is everywhere. Famous disease that's passed, interestingly enough, and we didn't know how it was spread. In the old days, it spread fecal to oral. It comes from contaminated water supply. This famous victim of polio, the late President Franklin D. Roosevelt. We have all those chats either seated or when they saw him in Congress, like in the very, this is a day that will live in infamy after Pearl Harbor. That was, he would stand up and he'd be standing when Congress entered. Okay. Spastic paralysis remain intact. Muscles are stimulated by reflex activity, no voluntary control, shortening because flexors overpower extensors. Lower motor and upper motor, the most famous disease that affects both of these, interestingly enough. Pardon me. Spastic is stroke. That's very famous amyotrophic lateral sclerosis or Lou Gehrig's disease. And again, a lot of very, very well-known people have unfortunately succumbed to that. So what happens when we transect, if it is, transection is between T1 and L1, we beget paraplegia. Remember, the cord stops L1 to L2. So paraplegia means your loss of lower extremity function, where quadriplegia, cervical region. And then again, spinal shock is something we see a lot with women. It would be like the Ryan Shazier case, where over time he regained a certain degree of function. One of the things and there's been a lot of athletes who they thought was spinal cord, we have better ways to deal with it. We have a lot of, the big problem is swelling from the damage. So they've used a lot of very sophisticated steroids. They've basically put them in not only inducing a comatose state using the steroids, but also chilling them down. So keeping their body temperatures lower would limit the deterioration. That was there. So all that, there's some interesting ways that was dealt with over time. Here's polio with the polio virus, and typically the people succumb from respiratory problems. You guys probably haven't seen a lot of post-polio syndrome. I saw plenty of it. Before we had the immunizations came in the 50s. From right here in Pittsburgh. One of our emeriti, his last name is escaping me, but I'll remember it for lab. He taught here for many years, and he was a resident, medical doctor, was a resident with Salk on the team that made the polio vaccine. Subsequently, they found that was a injectable vaccine, and they switched it to an oral vaccine. You did not know that. In the early 60s by Sabin, who was also at the university. And now we give it, because it's fecal to oral virus. So oral was more efficient than the way I got my initial thing. If you don't, you probably would not, if you talk to an older relative, even your dad wasn't around when this happened. In about 1964 or 65, they immunized the entire country month after month after month. I'll share that anecdote and we'll be done. So everybody, and imagine this. We went to your high school, your church, your community building. They had a roll of the census, all the doctors and nurses on a Saturday, and they get, in those days, a little sugar cube, and they put a drop of the vaccine, and you had it 1 month, and the next month it was trivalent. So you had 3 successive vaccinations that were done. Imagine in today's litigious society, where everybody should everybody else. I was at my buddy's house. His dad called my dad. I stayed overnight, like a kid would when I was 14 or 15. Okay. And he goes, oh, hey, Sid, that's my dad's name. He goes, we're going, we'll take Lou over to get the vaccination at the high school. And my dad said, oh, that's great. We're going a little early. We'll tell them. So I wasn't even with my mom and dad at age 14. And they said, oh, yeah, your dad and mom and dad were here. It says, fine, go ahead and give you the vaccine. How's that? You think that would happen today? Not happening. Not happening. Everybody would be so afraid they'd get sued and whatever like that. That's just give you an idea. That was like 64 or 65. Here's the Lou Gehrig's disease, terrible glutamate exocyticity. They're playing with it. All right, we'll leave it here. I'm a fountain of anecdotes.